Oh my God. I wish
Thank you.
if you get a biopsy like this, the ILD conference goes very different than if you get 2 pieces of bronchial epithelium.
I know.
Well, wait, I have the bronchial epithelia also.
I was gonna say we should all move to
Um,
Barcelona where they have really nice biopsies. I'm very jealous. It's also warmer too than Canada, so
That's true. The next case, case number 3, it's a 20-year-old man with multiple infections during infancy. He has just left infancy in 20 years. He has a suspected immunodeficiency, and the CT says OP. So,
have you guys noticed
Yes,
that the CT sometimes says OP, but almost never says DAD? It's very rare that the CT people make DAD diagnose. Do they make it, Irene, in your place?
No, I never paid attention to that, but I think so. Maybe they use another word. Maybe they use. I have to think what they say, but it's not DAD for sure.
I think they look for the
when they suspect the organization or organization no more. No, I don't know, but no, OP it's a frequent. You're so right. OP is a frequent CT diagnosis, but not DAD.
Yeah.
I think they look for the patient being intubated, and if the
Yes,
patient's intubated and or signs of that, then
yes.
then they'll
So
start
they're
saying,
cheating in a way, right? They're cheating because they're looking for clinical signs of ARDS before they call it DAD on the radiology. But if they don't have that, I've found that many cases that are absolutely clear-cut DAD on histology, right, with just hyaline membranes wall to wall, radiology calls it edema. That's what they usually call it.
Interesting.
Ground glass, diffuse bilateral ground glass, consistent with pulmonary edema is what they usually say.
Yeah, that's a good point. Good point.
When I say DAD, you talk to the radiologist and they say this could be DAD, but they never line that in the CT.
Yeah.
Say that, or never, or I don't recall having seen it. Well, who wants to take this history of the 20 years old man?
Sharda, do you want to do it or should I?
Sanjay, you please go ahead.
Okay, so let me try it. Okay, Rene.
Yeah.
So this is the one you originally showed to Matt, right? On the other one.
Yeah, this was a parakeet. Suspected parakeet.
No parakeet here. Here, there's a feather pillow, right?
No
Does the patient have a feather pillow?
Immunodeficiency. No, I don't know.
Feather pillow, mosaic attenuation. Okay, so let's get serious. So this is a very nice big piece of lung. There's a lymphocytic infiltrate in the interstitium. It's patchy. It's in both the pieces, more on the left-hand side piece, a little bit less on the right, but a lot of lymphocytes in the interstitium here and there. And other than that, I am struggling to see anything else that is useful here. Let's see. Maybe Rene will show us something more useful.
I wanted to point here that here there is pleura, for those that think that in transbronchial biopsies,
absolutely.
You can
Great point.
Pleura,
great point. And all the clinical articles, Irene, remember, said, oh, no, you can't diagnose UIP on a transbronchial biopsy because you cannot get to the periphery of the lung with a transbronchial biopsy. Wrong, because you frequently get pleura and chest wall and fat in transbronchial biopsies. Even a cryobiopsy, you've got pleura on that, which proves that you can get to the periphery of the lung. Okay, so anything else, Irene? Can you show me a little higher, Meg?
Yes. In my hospital, they go to 1 centimeter to the pleura, and then they get to the pleura and then retire a little bit.
Yes.
Not because they go back because they don't want to take the pleura because it can hurt the patient. But sometimes you have the pleura.
Yes.
I'm comfortable. I'm more comfortable with the pleura, I have to say.
Exactly. And our bronchoscopists say the same thing. No, we don't get pneumothorax. We bring the bronchoscope back. But you can't argue with the presence of pleura on a biopsy. I mean, that proves that you reach the pleura, right? And if you have a skeletal muscle or adipose tissue, even more evidence that you went into the chest wall and got it. So again, Irene, I don't really see much here. This is completely normal lung to my eye. Are you showing me something
a bit
significant?
of inflammation, not a bit of
Very minimal.
inflammation here, completely
Almost
not,
nothing.
very minimal. I
Almost
think this is normal.
Yeah.
This has some inflammation.
Inflammation, yeah. Patchy lymphocytes here and there. And there's some around the bronchioles too. Maybe there's slightly around the respiratory bronchioles and alveolar ducts.
This is very the more affected piece.
Yep.
And has inflammation.
Yes.
Bronchiolitis. We could say bronchiolitis maybe.
Absolutely. Agreed. Agreed. But I can't do anything more specific with this.
I'll tell you their suspicion as you want to throw it saying normal lung.
Yes.
They ask you specifically if the patient has lymphoid interstitial pneumonia or granulomatous lung granulomatous interstitial lung disease. Is that
Glilled?
Glilled.
Yes. Okay.
They ask you specifically what maybe once you have signed out this as, I don't know, some inflammation or how would you sign out this first?
Patchy interstitial chronic inflammation. See comment. And then explain that there is, some lymphocytic infiltrate around in the interstitium here and there, and some around the bronchioles. There is a mild chronic bronchiolitis, no granulomas, no fibroblast foci, no scarring, all the usual pertinent negatives. And there are no specific features of any named form of ILD. This is actually a kind of case that frequently comes to our multidisciplinary conference because there is no specific thing to call it, right? So you can pretty much make it into anything. But when this kind of case comes to ILD conference and they say, is this LIP? I would say no, this is not LIP. So LIP never has this kind of patchy infiltrate. It should have a diffuse and a very significant plasma cell component. It often has an airspace filling by this edema fluid kind of thing. And clinically, most patients have Sjogren's syndrome, so this nothing about this fits with LIP. The other thing is
LIP,
you said, yeah, go ahead.
The LIP that doesn't have OP, it is focal, but LIP by definition, I think doesn't has the Mason bodies. Do you agree to that or I made that? I know NSIP can have. Yes. NSIP can have, but LIP doesn't have the. But I agree that not only because of this, I would say that it's not LIP, but it's one thing more that LIP doesn't have.
Yeah, LIP has to have not just any lymphocytes anywhere in the interstitium. It has to have a striking, diffuse lymphoplasmacytic infiltrate that is so severe that you should be thinking maybe this is a lymphoma, maybe this is a mild lymphoma. So that's the kind of interstitial infiltrate that's LIP. If it's not, then I don't accept a diagnosis of LIP. The other thing you asked is about glilled. And about glilled, the interesting thing is that there is no repeatable, consistent pathologic features in glilled. It's some odd mix of lymphocytes and ill-defined granulomas here and there. So glilled, you can pretty much make it out of anything. It's not a pathologic diagnosis. It's a diagnosis that's based mainly on immunoglobulin levels. So if they said, could this be glilled? I could say, maybe. Do you have low immunoglobulin levels? There's nothing specific about this pathology that makes this glilled. Yeah. And the other thing I tell them about glilled is, although it starts with the word granulomatous, in the most glilled cases I've seen, it's the lymphocytes that are more prominent than the granulomas. It's not really chiefly granulomatous disease. But yeah, that they bring it up often because in cases that they think are sarcoidosis but don't have granulomas, they ask, could it be glilled? And I ask them, is there a low antibody level? Because there's nothing specific about the pathology. Does that make sense, Irene? Does that answer your question?
Yes. Well, I cite now this descriptively, as you said, patchy inflammation. But I agree that this is the typical biopsy that goes to the MDD. and it doesn't go one time, it goes one time and another time and another time.
Yes.
And even you get a call from some doctor that has that is looking at this patient, because this patient go to one doctor and to another, to different specialists, and you get that call because they know you reviewed that biopsy and they ask if it has this or if it has. So anytime it comes to, when these biopsies come to me, I make a comment with the date, with the suspicion. The patient has no lymphoid interstitial embolia because the infiltrate is not that striking, because it has OP, because it hasn't the exudate. It's not glilled because it has that or that. Just for me to remember that I have reviewed the biopsy and I have already said that.
Yeah. The other thing I'd like to say here is that, clinically, they can make this into anything depending on what the clinical setting is, right? Let's say somebody told you this has an anti-synthetase antibody syndrome, clinically has a, you'd say, yes, could be. Let's say they say they have 4 parakeets at home, you'd say, yeah, maybe this is hypersensitivity, it doesn't have granulomas. You can pretty much make this into anything depending on what the clinical setting is. It really, there's nothing specific in the pathology here.
I do that. If they say persistent pneumonitis, I'd say yes, it has pneumonitis, but it has no granulomas. so I cannot label that. Antisynthetase normally goes with DAD, so I don't see that. And this is what I do, because it's what you say. They have an idea and they ask you if this could be their idea.
Yes. Sharda, any ideas? So in your setting, how do you handle a biopsy like this?
Yeah, I just described this saying that there is moderate lymphoid inflammatory cells in the interstitium, and then I will give the differential diagnosis 1, 2, 3, 4. Yeah, I'll search for a granuloma first. In such cases, I'll go for deeper sections because in my experience, like the cases which I have signed out as HP, the deeper sections have revealed an occasional granuloma with a multinucleated giant cell. So I'll definitely go for a deeper section. I'll look out for granulomas, and then if nothing fits, then I will just give a list of differential diagnosis. And in that, I will include the HP, and then I will include the CTD as well, because of these lymphoid.
So Sharda, HP is in the diagnosis even if you don't have a granuloma, right?
Yeah.
Correct. So what is the point of doing the deeper level? Because when the deeper level brings up a granuloma,
no.
Still HP is still in the differential, right?
Only if the deeper level doesn't show a granuloma, then I'll still put a HP in the differential diagnosis.
Yeah. The point I'm trying to make is
along with the CTDs.
Yeah, exactly. So the point I'm trying to make is HP and CTD are always in the differential diagnosis, no matter what you see. It's almost pointless.
Sharada brought this thing, and I think that with cryobiopsy it's very important to. I get like 8 cuts, and we're staying with hematoxylin 4 the 1, 3, 5, and 7. And then I get one more, because I think with cryobiopsies and interstitial lung disease, it's interesting to see how things move. So to go around the bronchiole, or it gives you another dimension that you don't have with the cryobiopsy. It gives you more tissue when to go to deeper sections.
I have a question. So the deeper levels, so do you do special stains like Movat pentachrome or Masson trichrome or Warhoff Van Giesen elastin stains on this cryobiopsy instead of getting levels? Because then you can prove it's a central sampling, bronchiolocentric, or means obviously you can see that in H&E also. But what do you guys do?
Why would you do it, Raghav? So just explain why. So why would a trichrome stain be necessary to prove that it's central sampling?
It's not. That's why I'm asking. Instead of doing deeper levels, is there any value you can find in doing these additional stains to prove that mild interstitial thickening is because of fibrosis, which is highlighted by Masson trichrome, or even something like that?
I'm keen to hear what the others say. So what else would you do in a case like this, guys? Why would you do other stains?
all these 8 cuts and I have these unstained slides in the middle.
Yeah.
So I use these slides for things, but not for trichromic, that I think it's useless. I don't have this pen Movat that you have in America that is so beautiful. I don't know why. I have asked so many times, but they don't say this to me. Trichromic, Mason or Gomori, I don't know how to interpret that. I neither like pass for any ILD that is said to be pass positive. And what I find more useful is elastic stain. Elastic stains.
For what, Irene? So what do you
this
use the elastic stain for? What do you use it for?
For constructive bronchiolitis.
Oh, I see.
mostly,
Yes,
or
yes.
for constructive bronchiolitis.
Absolutely.
Is
Yeah, correct.
or the only, or maybe something if it's pleura or it's not, if it has not, but I don't use it always. I don't do it always. If I am in doubt with vessels or airway, I use this waiver Van Gison, I think it's the name.
Yes, VVG.
stains
Matt,
waivers.
what about you? Do you use like a stain to show fibrosis, or what do you use as special?
I don't, but some of my colleagues do, and the argument they make is it gives you a picture of the distribution and the amount of fibrosis at a very easily interpretable level. Like everyone agrees, yes, you can see fibrosis in the H&E, but a Masson actually, if you look at it at low power, you can very quickly get an idea of the extent and the distribution of fibrosis. So I have to admit it is nice for that, but I don't think you need it. It's more of there's a subtle nice to have, but it doesn't add anything. The only stain I do is if I'm ever worried about amyloid, I'll put a Congo red on it just to make sure it's not the fibrosis is not that. But in this case, I wouldn't do a Congo red because I don't see any eosinophilic deposits.
Yeah. I agree with all of that. I mean, I almost never do any other stains, but I agree, Matt, that it does look prettier when you do a, it makes it pretty. That's for sure. Yeah. And whoever said, Irene, about the elastic stain, I find that absolutely, gold for transplant biopsies where you're thinking about constrictive bronchiolitis. I find sometimes you will miss a case if you don't have the MOVAD there. So I think or whatever stain you use, I think it's very, very useful in transplant biopsies for obliterative bronchiolitis. No question about that. Very, very useful.
Do you see this biopsy normal, this piece? It has pneumonitis to my eye.
Yes.
This is not enough for lymphoid interstitial pneumonia, but
not to my eye.
Is this enough for NSIP to your eye? Any of your eyes?
I would say yes. I mean, if all the pieces look like this, I would say yes. This could be like a very mild cellular NSIP. Yeah. What? Sorry, Irene. What did you say?
This specific piece. I mean,
yes.
I struggle with this sometimes because you said this is normal. You said this is normal. Sanjay said
correct.
Normal.
Yes.
I don't see it perfectly normal, but I don't see, because I see more nucleus here than should be.
But they're all pneumocytes, right? Like, is there anything here that is a lymphocyte?
Maybe a few.
Maybe here.
Maybe
a few. I sometimes do a CD3 when I doubt when it's a bit collapsed or so. But I think here for me, this if everything looked like this and it's a big piece, this could represent NSIP.
Yeah.
Because NSIP is another thing I would like to bring up, because can we diagnose NSIP in a transbronchial biopsy? This is not big enough, maybe, to say something is not patchy, but can we diagnose NSIP in a transbronchial biopsy, cryobiopsy?
I don't think so, Irene. I strictly speaking, you cannot do it on a transbronch, and the reason is that if you had a surgical biopsy and you saw UIP features somewhere else, that would become UIP. But I think that by saying that this biopsy only has lymphocytes, you're essentially saying that it is NSIP-like. So
Yeah.
you're not really labeling it NSIP, but that's essentially what you're saying, that all it has is lymphocytes. So that's basically what it is. I mean, that's what cellular NSIP is, right? It's only lymphocytes. But I don't like to label things NSIP on a small biopsy because the clinician thinks, oh, the pathologist called it NSIP. But you cannot make a diagnosis of NSIP based on a small biopsy alone, because there can be something more significant away from where you sampled it. That's why I never diagnose NSIP on a.
Even if the radiologist
If-
says that it is NSIP, you don't diagnose an NSIP.
I don't,
on-
Sharda, because there are many times that the radiologist says NSIP and it is actually UIP. So just because the radiologist says NSIP does not necessarily make it NSIP for me. But that's my opinion. There are other people who would do it differently, I'm sure.
Because I had a case where the CT is saying that it is NSIP, and the biopsy, it was a cryobiopsy. It was also showing a NSIP pattern on the patient. The CTT workup was positive. So I signed that case as NSIP
Yeah.
with the company.
I understand the why you would do that. But I would ask you, Sharda, then why even do the biopsy? So if the CT is NSIP and you have a clinical, let's say an antibody or something like that, what are you looking for the biopsy to tell you?
No, the CTT workup was done later.
Yeah.
So it was a review case. So,
Yes.
so I came to know about the entire history because it was a review case.
Yes. No, I understand what you're saying. So let's say the CT is NSIP and the biopsy only has lymphocytes, what to do. So my personal approach to that is just to describe and say that this is what I see. I see fibrosis, I see inflammation, it's uniform, but I don't like to give it a definitive diagnosis because of the fact that it could be something else on a bigger biopsy. Now, could some of those be NSIP? Sure, they could be. Maybe on follow-up, those respond to steroids and go away, but I don't feel that is a definitive way to diagnose NSIP. I think you need a surgical biopsy for a definitive diagnosis. Could you guess based on small biopsy? Yes. You don't even need a cryo for that. You can do a transbronchial biopsy. And frankly, you don't even need a transbronch. If you're going to just guess and that's good enough, then you might as well do it on CT alone.
Agree.
Yeah.
I disagree. I mean I think that if I have 5 good pieces like this one and it showed more or looked not like this but maybe like this or look diffusely with inflammation, I say NSIP. It doesn't happen very often. I don't know if I have very few biopsies with NSIP, but I think that's it's okay that it's not definitive. If we diagnose what we see, and this is an NSIP, and we diagnose OP if we see OP, and it can be next to a tumor, and it can be OP in a idiopathic IPF, but because the patient has an inflammation. So this, if the biopsy is good enough, and I mean big pieces from 5 segments and all look with diffuse interstitial lymphoplasmacytoid, I think we should diagnose NSIP.
Yeah, my brain process is evolving now with all the comments. Like my thought process was exactly what Sanjay was saying: surgical lung biopsy, diagnose NSIP, but otherwise describe it in small biopsies. Now, like Irene posted new question to my brain process that if all the 5 pieces has got the features suggestive of NSIP, then would you call it? Then I'm standing here, one side I'm seeing the ocean, on other side I'm seeing the sea, which is very calm. Which side should I jump? Should I jump onto the ocean side or on the sea side? So if all the 5 pieces has got the features supporting, then why not call it? That's where my process is right now evolving.
Right.
But again, what I've learned or what I've thought, and then what I'm going to do, again, all this process, all this points which you guys are discussing would definitely help for our next
Can I
biopsy,
ask
which
you
is
guys a
coming my
question?
way.
So can I, Raghav and Irene both? So let's say you have this classic NSIP picture like this, okay? Let's say all lymphocytes. Irene, you're ready to hit the button on the NSIP diagnosis. And the clinician tells you, look, the CT is classic UIP. Would you still call it NSIP?
No, I said no NSIP. I say NSIP. Obviously, you cannot have UIP with no. You cannot have IPF with so much inflammation. It would be UIP from something else. Do you think there is IPF with all the biopsies without any fibrosis and with lymphoplasmas and looking like an NSIP? There's something else that we have to report.
Unlikely, yeah.
Maybe I don't think that they can make the mistake of saying honeycomb when there is not, or it's not it's a made up situation. But if I see a lot of fibrosis and I don't see healthy, when I don't get the fibrosis or I don't get the honeycomb, I see normal lung. And then I say, I have normal lung. This could be IPF because you are seeing the honeycomb someone else. But if I'm seeing 5 pieces of inflammation, this can't be IPF.
Yeah. No, good point. This is a great discussion to have because this happens a lot, this kind of biopsy you get very frequently. This is a great discussion to have. Yeah.